Assalamu alaikum everyone. Today we are going to learn about a medical emergency named diabetic ketoacidosis. In this module, we are going to learn what is diabetic ketoacidosis, what are the symptoms the patient will bring to you, and what are the signs you may found in the patient, and what are the investigation we are going to do for the diagnosis of diabetic ketoacidosis, and lastly, how to manage these patients. So this is my Tanzim, behalf of Clinical Eyes, going to represent today's module. So let's get started. Now, first of all, let us know what is diabetic ketoacidosis. Diabetic ketoacidosis is an acute metabolic complication of diabetes that is a consequence of absolute insulin deficiency. Now, in which diabetes you find absolute insulin deficiency? Yes, this is type 1 diabetes mellitus. But you may find diabetic ketoacidosis in patients with type 2 diabetes mellitus, and it is when there is a significant beta cell dysfunction. So, when there is a significant beta cell dysfunction in type 2 diabetic patient, you may find diabetic ketoacidosis in them. Now let us learn the cardinal biochemical features of diabetic ketoacidosis. There are three classical triads, namely hyperglycemia, hyperketonemia, and metabolic acidosis. You can see the levels of hyperglycemia in which blood glucose level is more than 11.1 millimole per liter. But now we consider diabetic ketoacidosis when blood glucose level is more than 250 milligram per dl. And the hyperketonemia, which is more than or equal to 3.0 millimole per liter on finger prick testing, and metabolic acidosis in which venous bicarb level is less than 15 millimole per liter and the venous pH is less than 7.3. But in fewer cases, DKA can occur without hyperglycemia, which is called euglycemic DKA. It is more common in the patient who are using SGLT2 inhibitors for managing their diabetes. Now let us solve a question for our exam. Which of the following is not included in the cardinal feature of diabetic ketoacidosis? As we previously mentioned, there are three classical triads of decay, namely hyperglycemia and its level, hyperketonemia, and metabolic acidosis. So we can easily answer the question that the correct answer is serum potassium level, which is not included in the cardinal feature of diabetic ketoacidosis. Now let us learn about the symptoms that patient usually brings to you. The symptoms are polyuria thirst, weakness, nausea and vomiting, and abdominal pain. And we will find the signs of dehydration, hypotension, tachycardia, tachypnea, or air hunger, which is also called Cosmos breathing. It means the pattern of breathing is Cosmos breathing, and the smell of acetone. To have a clear conception about the signs and symptoms of DKA, you have to know the pathophysiology of diabetic ketoacidosis or DKA. We have previously mentioned that in DKA, there is an absolute deficiency of insulin. So, in absolute deficiency of insulin, the counter-regulatory hormones of our body, namely growth hormone, glucagon, and cortisol. These three will induce proteolysis and lipolysis within the body. And due to lipolysis, there will be rapid accumulation of free fatty acid within the circulation. Now, in lack of insulin, the cells are unable to uptake glucose from the circulation. So cells are unable to uptake glucose from circulation. So there is a lack of energy production as the cells are not having and the proper amount of glucose. In this case, the liver will convert these free fatty acids into ketone bodies. And these ketone bodies will dump into the cell for the sake of energy production. But there is a problem with these ketone bodies that there are strong acids. So they will bind with the bicarbonate in the blood and it will lead to decrease the level of bicarbonate within the circulation that ultimately leads to metabolic acidosis. As we have mentioned, the counter-regulatory hormone, growth hormone, glucagon, and cortisol, it will also induce glycogenolysis and gluconeogenesis within the liver, and all these three mechanisms will lead to hyperglycemia. And we all know the renal threshold of glucose, which is 180 milligram per dl, and above this, glucose will appear in the urine, which is called glucosuria. Also, glucose is an osmotically active particle which will excrete along with water. So, there will osmotic diuresis. So, it will lead to dehydration. As there is a reduction in volume, so it will activate renin, angiotensin, aldosterone system. And aldosterone hormone tries to pull back the sodium and water from the renal tubules and excrete potassium from the body. So there may be a potassium deficiency, and due to loss of fluid, there will be hyperosmolarity, and all this will lead to acute renal failure. As we have learned the pathophysiology of diabetic ketoacidosis, we can now clearly understand the symptoms. As there will osmotic diuresis, patient will represent polyuria and thirst. And as loss of fluid and loss of electrolytes, the patient will have weakness and metabolic acidosis due to accumulation of hydrogen ion. It will trigger the chemoreceptor triggering zone within the brain, which will induce nausea and vomiting. And due to hypokalemia, there will be abdominal pain. As you have mentioned, that there is lots of fluid going out from the body, the oral cavity of the patient becomes dry and we find the sign of dehydration. And to compensate the hypotension, there will be tachycardia and there will be a smell of acetone. Now, we all know that the ketone bodies are namely aceto, acetate, beta hydroxy butyrate, beta hydroxy butyrate, and lastly, acetone. We all know that acetone is excreted through the respiratory route, so there will be a smell of acetone, which is apple-like smell or sickly sweet smell or sickly sweet smell. Also, there is a mention about the breathing pattern which is called Cosmos breathing. Now let us see what is Cosmos. In this video, we can see the breathing pattern of the patient is Cosmos breathing. This breathing pattern is called Cosmos breathing. Now let us learn the causes of diabetic ketoacidosis. A patient having type 1 diabetes mellitus, if he have any current infection like pneumonia, UTI, and pancreatitis, and others, in this infectious condition, the counter-regulatory hormones of our body, namely growth hormone, glucagon, and cortisol, will suppress the activity of insulin. As they're suppressing the activity of insulin, it may lead to insulin resistance. So in insulin resistant, the demand of insulin within the body will increase. For example, a patient having 3 units of insulin per kg per day, due to insulin resistance, the demand will shift to 5 units per kg per day. So the patient, unknowing about this phenomena, will take 3 kg, 3 unit insulin per day. For as a result, there will be a lack of insulin, which may lead to diabetic ketoacidosis. Further, there will be non-compliance with insulin treatment. It means the patient is not taking insulin regularly. Also, there are other causes of decay like infection, drug abuse, and pregnancy. But there is a thing to mention that there are no obvious reason why there is diabetic ketoacidosis. Now, let us solve a question. A 16-year-old man present with a history of malaise, weakness, vomiting. He diagnosed with insulin-dependent diabetes mellitus 3 years previously, means it is a type 1 diabetes mellitus. Which of which one of the following supports a diagnosis of diabetic ketoacidosis? As we can see the option for our previous study, we can learn by the three cardinal we have learned the three cardinal feature of diabetic ketoacidosis. From them, we can easily answer this question. Is that the correct answer is a serum standard bicarbonate of 10 millimole per liter. We have learned that if the serum bicarbonate level is less than 15 millimole per liter, it will diagnose as diabetic ketoacidosis. The other options are not that much reliable for this diagnosis. Now, what are the investigation you have to do in for the diagnosis of diabetic ketoacidosis? We have to do blood sugar level, blood analysis of ketones, urea and electrolytes, plasma bicarbonate level, ABG and or arterial blood gas analysis for know the status of metabolic acidosis, serum amylase, ECG, chest X-ray, if there is any consolidation or pulmonary edema, and infection. For infection, we have to do CBC or full blood count and blood and urine culture, and also lastly pregnancy test. So there is another question. Which of the following investigation is not a part of management of decay? As we have seen the investigation, we can easily answer that the correct answer is liver function test. The correct answer is liver function test. As there is no mention of liver function test, it means it is not that much significant in the investigation of diabetic ketoacidosis. Let us know the diagnostic criteria of diabetic ketoacidosis. As you can see these two charts, you can easily understand. Now let us learn about another important topic, which is called severe diabetic ketoacidosis. So in this situation, the ketone bodies is more than 6 millimole per liter, bicarb level is less than 5 millimole per liter, and the venous or arterial pH is less than 7. And also, there will be systolic blood pressure less than 90 millimeter of mercury. Oxygen saturation is less than 92% on year, and the GCS score is less than 12, and there will be hypokalemia, and also an anion gap of more than 60 millimole per liter. So there is another question that a patient has been diagnosed with DKA. Which of the following is an indication of severe decay? As we have learned the indicators of severe decay, we can easily answer this question. We know the correct answer now. The correct answer is oxygen saturation is less than 88% on the year. We have learned that if the oxygen saturation is less than 92, it will diagnosed as severe diabetic ketoacidosis. So now let us learn the management of diabetic ketoacidosis. As the patient have come to you in the emergency ward and you have suspected that it is a case of diabetic ketoacidosis, now you have to quickly manage this patient. At first, you have to do two IV line in the patient and take a blood sample from the patient and quickly send it into the lab for the assessment of blood sugar level, blood ketone level, and serum electrolytes level. But at first, before having the lab report, you have to do fluid replacement in the patient. And how to calculate the fluid deficit in the patient? And if the patient is 60 kg, the typical fluid deficit in the patient should be 16 to 100 ml or 6 liter. And you have to replace this 6 liter of fluid in the patient. For this, you have to give 1 liter of 0.9% normal saline at first hour. Next 1 liter have to give within the next 2 hours, then 1 liter in next 4 hours, and so on. If the blood pressure in the patient is less than 90 millimeter of mercury, you have to give 500 ml of bolus normal saline over 10 to 15 minutes at first. And further, you can follow this method. After having the lab report, we can start insulin infusion now. But before that, we have to concern about the potassium level in the patient. If the potassium level in the patient is less than 3.5 millimole per liter, never start insulin first. Because we all know insulin push potassium into the cell, which can lead to hypokalemia. And hypokalemia results in cardiac arrhythmia and cardiac arrest. So, avoiding this, we have to start insulin supplement, potassium supplementation first. We have to give 40 millimole per liter potassium chloride supplementation. And after that, if the potassium level is more than 3.5 millimole per liter, then now we can start insulin infusion. But there may be other scenarios like if the potassium level is within the normal range, also you need to add potassium supplementation to avoid hypokalemia. And if the potassium level is more than 5.5 millimole per liter, you need not to add is potassium supplementation. Now, let us learn how to extract insulin infusion. At first, we have to give a bolus insulin. As the patient is 60 kg, we have to give 60 into 0.1 unit or 6 unit insulin bolus at first. Then we can start insulin infusion at a rate of 0.1 unit per kg per hour. As we start insulin infusion, it will correct the hyperglycemia, hyperketonemia, and metabolic acidosis. As the blood glucose level is decreasing, if it decreased below 14 millimole per liter, now we have to start glucose supplementation or glucose dextrose saline. After all this, as the blood ketone level have fallen below 0.6 millimole per liter and the venous pH is more than 7.3 and the bicarbonate is more than 15 millimole per liter, now you can stop insulin infusion. But before stopping insulin infusion, we have to give a subcutaneous long-acting insulin to the patient. Subcutaneous long-acting insulin to the patient. And after fulfilling all the requirements, now you can shift the patient from the ICU to the normal ward, then educate the patient and adjust his insulin dose and advise the patient to take insulin regularly. After learning about the management of TKA, let us solve a question. A patient with diabetes mellitus come to you with unconscious state. Investigation shows blood glucose level is more than 30 millimole per liter, serum osmolarity is 50 milliosmol per kg, and the ketonemia is 1 millimole per liter. What would be the initial treatment? As you have learned that the first duty of your management is to the correction of fluid. So, the correct answer should be IV fluid. Now, lastly, let us learn about the complications of diabetic ketoacidosis. These are hypoglycemia, hypokalemia, pulmonary edema, acute respiratory distress syndrome, and the most devastating complication of diabetic ketoacidosis is cerebral edema. So this is all about our today's module. Thank you for watching our video, and you are requested to like and subscribe our page for getting further videos. Allah Hafiz.